Good morning, all. Myself, Dr. Terence, Reader in Department of Orthodontics in Royal Dental College. So today I am going to discuss a topic on occlusion. What is occlusion and the basic concepts of occlusion? There are mainly two aspects of occlusion. One is static and other is dynamic. Static means it is refers to a form, alignment and articulation of teeth within and between the arches and relationship of teeth to the supporting structures. And dynamic refers to it is a functional aspect of stomatognathing system. It is the occlusion when jaws are in motion. So basically, dynamic occlusion is an occlusion or it is a relation between upper and lower teeth when the jaws are in motion. And static occlusion means when the jaws are in a stationary situation. And occlusion, we all know occlusion is a complex phenomenon involving numerous commodities such as teeth, periodontal ligament, jaws, TMJ, muscles, and the nervous system. What are the definition of an occlusion? Occlusion is defined as the manner in which the upper and lower teeth intercuspate between each other in all mandibular positions and movements. It is a result of neuromuscular control of the components of the mastication systems, namely teeth, periodontal structures, maxilla, and mandible, as well as temporomandibular joints and their associated muscles and ligaments. These components are commonly known together as a somatognathing system. So basically, occlusion, it is the maximum intercuspation between the upper and lower teeth, which involves various components of the somatognathing system. Then coming to the next slide. Yeah, there are various terminologies related to occlusion. First is what is ideal occlusion? Ideal occlusion is simply it is a theoretical concept. It is according to Houston, it is the concept of ideal occlusion, such as there will be an ideal mesiodistal as well as buccolingual inclinations of the teeth, and there is a ideal contacts between upper and lower teeth, as well as the upper arches should overlap the lower arches. And another concept of ideal occlusion suggested by Houston is mandible should be is in a centric relation. During mandibular excursion, or in the case of functional relationships, all the relationships should be in the correct. That means when we protrude the mandible, or if there is a lateral movements of the mandible, all the relation between maxilla and mandible should be in the proper way. The second concept is physiological occlusion. It is ideally, it's not a ideal occlusion, but it is a slight deviation from the ideal occlusion, but it is well adapted to that particular environment. What is balanced occlusion? Balanced occlusion we can't see in the human beings or in our mastication process. The balanced occlusion we can only see in the dentures. It is the equal contact should be maintained throughout the entire arch during all the excursive movements. So when we protrude the mandible or when we shift the mandible in the lateral direction, all the tools should be equally contact with each other. That is balanced occlusion, which is not practical for human beings or our normal natural occlusion. Coming to the next slide, what is functional occlusion? It is the it provides the highest masticatory efficiency during all the excursive movements. Excursive movements, it is the abnormal or it is the lateral movements or protrusive movements of the mandible. So during all these excursive movement, there should be a maximum efficiency of mastication. That is functional occlusion. What is therapeutic occlusion? It is a modified occlusion because of the therapeutic treatment or therapeutic modalities or various treatment modalities after the orthodontic treatment, but which will be more similar to that of the physiological manner. What is traumatic occlusion? It is an abnormal occlusion which can produce stress in the masticatory apparatus or components. Trauma from occlusion. It provides the abnormal occlusal contact leads to periodontal tissue injury. What is primary occlusal? There are two types of occlusal trauma: primary occlusal trauma and secondary occlusal trauma. Primary occlusal trauma means there will be an injury to the periodontium from the occlusal loading, which has an excessive force or excessive magnitude. So it is an abnormal force on a normal periodontal ligament, which which produce a primary occlusal trauma. What is secondary occlusal trauma? It is the injury to the periodontium from occlusal loading of even the normal forces. That means even the normal masticatory forces can produce the injury to the periodontium. That because of already the periodontium is weak in such patients or in such cases. So normal forces are acting on a weak or abnormal periodontal ligament or abnormal periodontal apparatus. That is the secondary occlusal trauma. Coming to the next slide, the unit of occlusion is it is a cusp to fossa relation. That is the unit of occlusion. Cusp, we all know it is the conical shaped or pointed or rounded eminence, but fossa it is the deepened or concavities. So cusp should occlude over the fossa. What are the various types of cusp? There are centric holding cusp and non-centric or non-supporting cusp. Centric holding cusp is also known as stamp cusp. What is stamp cusp or centric holding cusp? They are the cusp which participate in the masticatory process. These cusp are the facial cusp, buccal cusp of the mandibular arch, and the palatal cusp of the maxillary posterior teeth. These cusps are known as centric holding cusp. What is non-supporting cusp or shearing cusp or guiding cusp? These are the cusp which support or which prevent the spillage of food during masticatory process. These are the maxillary buccal cusp. That means buccal cusp of the maxillary posterior teeth and lingual cusp of the mandibular posterior teeth. These are the non-supporting or guiding cusp. Coming to the next slide, non-functional cusp prevent the food. That is, as I told before, these non-functional cusp or supporting cusp which prevent the food escaping from the occlusal table, and it also protect the buccal mucosa from mastication or chewing, which can produce ulceration. What is plunger cusp? These are the cusp that tends to forcibly wedge food into the interproximal area of two teeth of the opposing arch. So example for plunger cusp are distolingual cusp of the upper second molar. So this upper second molar distolingual cusp, which during mastication they wedge food into the interdental space of the lower teeth. They are known as plunger cusp. Coming to the arrangement of teeth in humans, there are mainly two types of arrangement of teeth in humans. One is cusp to fossa occlusion and other is cusp embrasure occlusion. Cusp fossa occlusion means cusp fossa relation, that is stamp cusp of one tooth occludes in a single fossa of the opponent tooth. Cusp embrasure means one tooth occludes over the interdental area between the two teeth, the opposing arch. The main advantage of cusp fossa over cusp marginal ridge pattern of occlusion means cusp fossa relation which produce maximum interlocking of upper and lower teeth. Thereby, it can direct forces along the long axis of the teeth, which produce the efficient chewing during mastication. Coming to the various imaginary occlusal planes and curves, there are mainly three imaginary curves and planes. One is curve of P, curve of Wilson, and curve of Monsoon. So you might have heard these things during your first year in the preliminary classes. So what is curve of P? It refers to it is an anterior posterior curvature of the occlusal surfaces. So in this figure, you can figure out in the first figure, you can see it is an anterior posterior curvature starting from the cusp tip of the canine buccal cusp of the premolar Buccal cusp of the molars, when we extend posteriorly, it extends to the condyle to form a circle of 4-inch diameter. That is the curve of P. The another curve is we draw the same curve in the maxillary arch. It is known as reverse curve of P. So curve formed by cusp and incisal edge of the maxillary teeth, it is reverse to that of the curve of P seen in the lower arch. What is curve of Wilson? It is the in this figure, in the second figure or down figure, you can see it is a mediolateral curvature formed between the buccal and the lingual, or buccal and lingual cusp of the lower posterior teeth. So in this curvature, there is a lingual inclination of the lower posterior teeth, which helps to direct the forces parallel to the medial pterygoid muscles. So it is a mediolateral curvature on each side of the arch. So curve contacts the buccal and lingual cusp tip of the mandibular posterior teeth, which result in lingual inclination of the posterior lower posterior teeth. The main advantage of this curve of Wilson is the teeth are aligned parallel to the direction of the medial pterygoid. So it can produce optimal resistance to the masticatory forces. The elevated buccal cusp prevents the food passing out or escaping from the occlusal table during mastication. But its curve of Monsoon, it is obtained by extending the curve of P and curve of Wilson in all the cusp and the incisal edges. So it is a combination of curve of P and curve of Wilson. It is known as curve of Monsoon. So these figures, first figure, it is mentioning about the anterior posterior curvature, that is curve of P. Down figure, it is a mediolateral curvature, that is curve of Monsoon. Sorry, curve of Wilson. Coming to the various terminologies. What is centric relation or terminal hinge position? So it is the relation of mandible to the maxilla when the mandible is in the most retruded and unstrained position from which the lateral movements can performed. So it is the definition of the centric relation is, it is a maxillomandibular relationship in which the condyles articulate in the thinnest avascular portion of their respective disc, that is TMJ disc, with the complex in the anterior superior position against the shape of the articular eminences. So simply centric relation, it is the maxillomandibular relation at which the condyle is positioned in the anterior superior posture of the anterior superior position of the articular eminence, isn't it? So it is the most retruded position of the mandible. What is centric occlusion? It is the relation between upper and lower teeth when the mandible is in the centric relation, that is centric occlusion. What is maximum intercuspation or habitual occlusion? It is the maximum intercuspation of opposing teeth, which is independent of the condylar position. The maximum at the habitual occlusion is 1 to 2 mm forward to the centric relation. So here you can see the centric relation. Condyle is positioned in the anterior superior position of the articular eminence. This is the articular eminence. Condyle positioned anterior superior position of the articular eminence. And during the centric relation, the relation of maxillary and mandibular tooth is known as centric occlusion. As I told before, centric relation or terminal hinge position, it is a maxillomandibular relation when the condyle is at the anterior superior position of the articular eminence or and posterior superior position of the clinoid fossa. What is centric occlusion also? I have mentioned it is a intercuspation between the teeth when the condyle is in the centric relation. There are two types of centric condyles. That means the area of the teeth that condyles the opposing teeth is known as centric condyles. There are two types of centric condyles: posterior centric condyles and anterior centric condyles. Posterior centric condyles are the buccal cusp of the mandibular posterior teeth and the lingual cusp of the maxillary or palatal cusp of the maxillary posterior teeth. So buccal cusp tip of the mandibular posteriors contact the central fossa and mesial marginal ridge of the opposite maxillary teeth. and the palatal cusp of the maxillary posterior teeth occluding the or contact with the central fossa as well as the distal marginal ridges of the opposing mandibular teeth. There are two anterior centric contacts. These are the posterior centric contacts. Anterior centric contacts, it is very simple. That is, lower anterior teeth are contact the lingual fossa region of the upper anterior teeth. What are the poded centric contacts? Poded centric contacts are the contacts on the cuspal inclines. In centric occlusion, each tooth of the maxillary or mandibular arch occludes with the two opposing teeth. So when upper and lower teeth are occluding in the centric occlusion, each tooth contact with the opposing at least two teeth. These contact points are known as poded contacts. So when we see in this figure here, the upper teeth is contact with the lower teeth at two points, at two sites. So it is two poded and this is single poded. So these are the various contact points you can see in the maxillary arch and various contact points you can see in the mandibular teeth when the maxillary and mandibular teeth are in the centric occlusion. So this is the centric occlusion. So when we shift the mandible to one side, the side is known as working side and the opposite side is known as non-working side. When we shift the mandible to one side, so there will be a shift in the condyle in that side. So when we shift the mandible to right side, what happened to the right condyle? The right condyle will pivot inside the glenoid fossa and left condyle moves or which glides in the medial as well as forward and downward direction. So that movement of the condyle in the non-working side is known as Bennett movements of the condyle. So these are the various eccentric occlusion. What is eccentric occlusion? Any occlusal relation other than centric occlusion is known as eccentric occlusion. What are eccentric contacts? Contact of teeth that occurs during movement of a mandible. That means when we protrude the mandible or when we shift the mandible right or left, which all contacts happens with the mandibular teeth with the maxillary teeth are known as eccentric contacts. There are two types of eccentric occlusion, functional as well as non-functional. Functional occlusion is also known as working side occlusion. That means there will be a tooth contact which occurs in the segment of the arch towards which the mandible moves. For example, when we move the mandible, shift the mandible to the right side, wherever the contacts of tooth, upper and lower teeth takes place in the right segment or right side of the arch, which is known as functional occlusion. There are two types of functional occlusion, lateral functional occlusion and protrusive functional occlusion. Lateral functional occlusion means when we shift the mandible laterally, either left or right side, there will be a tooth contact on the side with which mandible moves. So normally the canines will be at the contacts as well as posterior teeth also may be contact in the side where the mandible moves. That is lateral functional occlusion. There are two types of lateral functional occlusion, canine guided occlusion as well as grouped lateral occlusion. Canine guided as well as grouped lateral occlusion. Canine guided occlusion during lateral movement of the mandible, the opposing upper and lower canine of the working side contact each other and thereby there will be a disocclusion of all the posterior teeth both working as well as balancing side. This canine guided occlusion can be seen in the young individual with the unworn dentition. That means when we shift the mandible to right side, there will be a contact between the upper and lower canine in the working side, that is the right side, and there will be a disocclusion of all the posterior teeth in the right side as well as the posterior teeth in the left side, or there will be a disocclusion in the left side, that is the non-working side. That is canine guided occlusion. Grouped lateral occlusion means in addition to the canine, in the working side, there will be a contact in the posterior teeth. That is grouped lateral occlusion. What is protrusive frontal occlusion? And when we protrude the mandible or bring the mandible forward, there will be a contacts in the lower anteriors, incisal tip of the lower anteriors with the palatal inclines of the maxillary anterior. That is protrusive frontal occlusion. Then coming to the non-functional occlusion, or it is also known as balancing side occlusion. It is the teeth contact occurs in the opposite side of the mandible moves. That means there will be a disocclusion in the opposing side or non-working side from which the mandible moves. What is Bennett movement? The lateral movement of mandible results in rotating working side condyle and medial movement of non-working side condyle. That I have already mentioned. When we shift the mandible to right side or any side, so the side with where mandible moves is called working side. The opposite side is known as non-working side. So in working side, there will be a pivot movement of the condyle, and in non-working side, condyle moves medially downward and forward. That is Bennett movement of the condyle. The angle formed between the condyle with the glenoid fossa is known as Bennett angle. What is mutually protected occlusion or canine guided occlusion? It is a normal feature you can see during the normal occlusion. It is the eccentric occlusion, only posterior contact occurs and anteriors are out of contact. It is known as, these are the concepts of mutually protected occlusion. Moreover, in eccentric movement, in protruded contact position and lateral working contacts, posterior teeth are disoccluded and only canine contact in the working side. That is mentioned already before. What is disocclusion? It is the separation of non-functional posterior teeth during eccentric movements of the mandible. What is condylar guidance? It is the path taken by the condyles along the slopes of the articular eminence during eccentric movements. That, as I told before, when the mandible moves to one side, so the path taken by the condyle along the glenoid fossa in the working side as well as non-working side. That movement of condyle is known as condylar guidance. During protrusive movement, what happens? Condyle translates the downward along the slope of the articular eminence, leading to the separation of the posteriors. So coming to the next, as well as same thing during the various paths taken by the condyle during protrusive movement as well as during lateral movement of the mandible, that as I mentioned before. What is incisal guidance? Incisal guidance is, it is the inclination of lingual surface of the upper anteriors which separates the posterior teeth during eccentric motion of the jaw. That means during protrusive movement of the mandible, there will be a sliding of the lower incisal tip of the lower anteriors along the palatal surface, palatal inclines of the upper teeth, which cause separation of the posteriors. So during protrusive and lateral mandibular movement, the lower anterior teeth track downward from centric contact toward the incisal edges of the maxillary teeth, leading to dissolution of non-functional posterior teeth. Coming to the Andrews 6 keys of normal occlusion. What is 6 keys of normal occlusion? Andrew conducted a study in 1970. He collected various samples, studied about various occlusion. That is, he collected 120 patients with ideal occlusion. So his sample was 120 patients with ideal occlusion. To he observed them for various years and he found out various norms. First is intermolar interarch relationship, that is simply class 1 molar relation. That is the, we all know it is a mesiobuccal cusp of the maxillary permanent first molar occludes in the buccal groove of the mandibular first permanent molar. That is class 1 molar relation. So there should be a class 1 molar relation for normal occlusion. Second key is crown angulation. Crown angulation. That means it is a mesiodistal angulation of the crown. Normally, the gingival margin of the gingival part of the crown should be distal to the incisal part in the of the clinical crown. In this figure, you can see in the second figure, anteriors, upper anteriors, the long axis you can see the gingival part of the long axis of the clinical crown is distal to the incisal part. That is the angulation, crown angulation. Then the left figure you see that is the crown inclination. So that means there is a inclination of the or palatal inclination as well as lingual inclination of the posteriors. So third key is the crown inclination. That means there will be a positive crown inclination in the upper anteriors and negative crown inclination in the lower anteriors as well as upper and lower posterior. That means the upper anteriors, the roots are directed palatally, but in lower anteriors, roots are directed labially. That is slight negative inclination. And the upper and lower posteriors, you can see there will be a palatal as well as lingual inclination of the roots of the upper and lower teeth. That is negative crown inclination of the upper and lower posteriors. And fourth key, there should not be any rotation of teeth in the dental arch. Fifth key is there should be a tight contact between the adjacent teeth. Sixth key is the curvosity. That means the normal occlusal plane according to Andrews should be flat. So curvosity should not be more than 1.5 mm. And there will be a one more key, that is the seventh key. It is the Bolton's ratio, which is considered as the seventh key. It is the arch tooth length, tooth size discrepancy between the maxillary and mandibular arch. That is the Bolton's ratio. It is the seventh key of normal occlusion. Coming to the various Roth's goals of biological occlusion. According to Roth, he he proposed various goals for normal biological occlusion. The first goal is there should not be any interference between centric relation and centric occlusion. There should not be a balancing contacts in the there should not be any contact in the non-working side. There should be a cusp to fossa relation, and there should be a minimum of one contact per tooth during occlusion. What is cuspid rise? It is a group functional occlusal scheme. There should be a grouped occlusal. That is, as I told before, there should be a grouped functional occlusion. That means during the lateral movement of the mandible, both canine as well as the posterior tooth should come in the contact. There should not be any posterior contact during protrusive movement of the mandible. Eliminate the occlusal contacts on inclined planes to enhance the positional stability of the teeth. Eliminate all the possible fremitus, that is the functional mobility of the tooth. If there is any, for example, if there is any that is any during the occlusion or during mastication, if there is any high point or which interferences between the upper and lower teeth, we should eliminate the interference which can create trauma from occlusion or thereby which results in the mobility of the teeth. When the operator is able to manipulate the mandible with little or no resistance from the patient, the muscles of mastications are considered to be in a relaxed state. This means that the occlusion is progressing towards harmony with the muscles of mastication. So when we examine a patient, so when we manipulate the mandible, all the muscles of mastication should be in a relaxed state. That is the postural assessment of the postural rest position that we have studied during when we come for clinics. So we do all our exercises during postural rest position. That means all the muscles are in a relaxed state. So patient can able to position the mandible in the centric relation. So coming to the next concept, that is centroid theory. Centroid theory is introduced by the Houston. That means the incisal edges of the lower incisors should be anterior to the centroid of the roots of the upper central incisors. What is centroid? Centroid, it is a geometric center of the root of the maxillary anterior tooth. It is the geometric center of the root of the maxillary anterior teeth. So the incisal tip of the lower anterior should ahead of that geometric center of the roots of the maxillary anterior teeth. In case of class 2 D2, we can see there will be a lingual inclination of the maxillary anterior teeth. Because of this lingual inclination, the incisal edge lies behind the centroid of the maxillary anterior root. According to Austin, according to centroid theory, the lower incisal edge should be ahead of the centroid of the upper anterior root. So, I hope you have you understood some concepts about the occlusion. So, if you have any doubt, you can ask me at any time. So, I am winding up the class. Thank you for your cooperation as well as patience to listen my topic. Thank you all.